So, hi, I'm Kai from Yonsei University. Today I'm so honored to have the chance to share work here at ISBI. So this work is called Evidence-Empowered Transfer Learning for Alzheimer's Disease. So transfer learning is a common solution to lack of image data in the medical domain, and it often involves training a model with an irrelevant auxiliary task and transferring the knowledge to the target task. And however, such a setting usually works as a black box where we can't really explain what exactly is helping the model to learn medical images. And the major discrepancy between the medical and general domain has been shown to potentially lead to negative transfer. So we thought, what if we can utilize the knowledge that is relevant to Alzheimer's disease? As we know, a human brain consists of several brain regions, and the morphological features of them are highly correlated to AD. So inspired by that, we present an AD-relevant auxiliary task for named morphological change prediction, MC prediction, to learn the morphological features of the MRI scan, which is the knowledge that related to AD. Here we argue that such knowledge is the evidential knowledge for AD detection, as the whole process of MC prediction imitates the real clinical settings where the radiologist they read the MRI scan and find clinical evidence to support their diagnosis. So unlike the conventional approach, our framework uses an AD-relevant auxiliary task, which requires no need of additional MRI data, and the knowledge learned is the evidential knowledge for AD detection, which brings the performance gain with less data. So like I said, the MC prediction requires no additional data. What we did is we take the same MRI data set for AD detection, and for every brain regions in the MRI scan, we categorize them into 3 severity classes according to their volume measurement automatically. So for the further details on the annotation process, please refer to our paper. So during training, the model is given a patient MRI scan, and it's trained to predict the morphological features, the severity level of a brain region's atrophy or enlargement. So now let's dive into how we perform the knowledge transfer. When training a diagnostic model, the model M predicts the label Y based on the input X and update its parameter theta. Here, the label Y is the target of the task, and the initial value of the parameter theta can be considered as the prior of the model. With that in mind, allow me to elaborate how we transfer the evidential knowledge to AD detection as model prior, target, and input. So the first setting is evidence as prior, where we first train the model on the MC prediction task, and after that, the parameter learns from the MC prediction is used as the initial parameters for the training of AD detection. And the second setting is evidence as target, where the morphological features are used as the additional training target for AD detection in the multitask learning scheme. And the last setting is evidence as input, where we first train the model for MC prediction, and we build a second encoder for the AD classification. And we reuse the encoder for MC prediction as the feature extractor, which extracts the evidential knowledge of the evidential knowledge. And we concatenate the evidential knowledge and the features from the second encoder as the input for the classification layer. Since then, the extractor and the second encoder are jointly trained to update, to minimize the loss for AD detection. So now let's move on to the experiment. So for baseline, we use the pre-trained CNN and the randomly initialized CNN. As the inputs are 3D images, instead of ImageNet, we use a combination of 2 large-scale 3D datasets of short videos and which has been widely utilized to train 3D CNN. So our experiments are guided by 3 research questions. The first one is, does our framework improve AD diagnosis? As we can see here, all of our settings achieve higher detection accuracy than the baseline, regardless of the capacity of the model. And we also observe negative transfer here, and this supports the necessity of our effort to try to utilize the knowledge that is related to AD. And in the second experiment, we investigate how evidence empower our framework. So that is, we test if the model can make predictions that reflect the changes in evidence faithfully. So what we do is we take an MRI scan and we add noises to brain populations with severe atrophy or enlargement. In other words, we corrupt the evidence in the MRI scan. So by doing so, we got a counterfactual sample of the original sample. And then we pass both of them into a diagnostic model. So the logic here is that a trustworthy model should make predictions that reflect the changes when the input features are modified. So we measure the difference in predicted probabilities. So these charts are the result of the experiment. The first being indicates the number of original and counterfactual sample pairs that yield similar diagnosis, with small difference in predicted probabilities less than 2%. So the lower the first bin is, the better the model reflects the changes of input features in their diagnosis. So the results show that our models can make a more trustworthy prediction that are faithful to its input features. As for the last research question, we experiment on varying amount of training data to see if our framework can still be effective in data scarce scenario. So we found that no matter how much data we give to the model, our settings always outperform the baselines, especially when only 25% of data were given. Our settings achieve much higher performances than the baselines. Moreover, when comparing our model with the baseline trained with 100% of the data, our evidence as prior and input achieve higher accuracy with only 50 and 75% of the training data, and higher AURC with only 75% of data. And this shows that our framework is effective even when the data is limited, which is an important property in medical domain. So let's wrap things up with the takeaways of this paper. We present an evidence-empowered transfer learning for Alzheimer's disease, and we explore the different ways of knowledge transfer. And by applying our framework, our models outperform the baselines, regardless of model capacity and the data and the size of data. And we also manifest the faithful and trustworthy nature of the diagnosis. And as our framework is label efficient, we presume that it can be applied to other medical fields to mitigate the data scarcity problem. So here it is. Thank you for listening to my presentation today. I hope you guys all stay healthy and have a nice week here at Cartagena. Thank you. Gracias.